All right, let's get going. Hi everybody, I'm Jason. So, backslide Brianna, Director of Sports Cardiology at Stanford and Chair of the ACC Sports and Exercise Committee for the California chapter. Brianna, I can go back a slide. I'm just going to introduce our panelists here. Today we'll be talking about AFib in athletes. So moderating will be myself and Tim Kanan, who's an interventional cardiologist at UCLA. Our case presenters are Dr. Brianna Collins, internal medicine resident at Stanford, and Dr. Brian Keefe, cardiologist at Marin Health and the director of the Cardiovascular Performance Center at Marin Health. And then we have our expert panelists. First one being Dr. Cecily Dye. She's an electrophysiologist and director of the EP lab at the Naval Medical Center in San Diego. Then we have Dr. Perez, associate professor at Stanford and the director of the Inherited Cardiac Arrhythmia Clinic at Stanford. And then finally, we have Dr. Vivek Iyer, who's an electrophysiologist at Marin Health. Next slide, Brianna. So just to summarize, we did our last seminar a bit ago, almost a year ago. We talked about accelerated CAD, specifically coronary calcification in athletes. The main thing being that there's a pretty robust amount of literature showing that there's accelerated CAC in ultra endurance athletes, and that's been shown over study in the last 15 years or so. Next slide. Then there was this one paper published last year, kind of changes the picture a little bit, observational study, but this one actually described higher risk lesions and soft plaques in proximal vessels in endurance athletes. So changing the narrative a little bit. There's one study, but it goes against the grain of the previous many studies. And then almost a year later, since that slide was published, we have this study, which was just recently published from the Cooper Clinic and Ben Levine's group at UT Southwestern. And here, they looked at over 8,000 individuals and evaluated their coronary calcification in relation to their physical activity. And here they actually found that, looking at the graph on the right, that yes, as all the other studies confirmed, more physical activity was associated with more coronary calcification. But if you look at physical activity level longitudinally, increased physical activity wasn't actually associated with increased progression in coronary calcification. And then figure 2 on the left here, we see if we use that threshold of 100 Agatston units, marking clinically relevant coronary calcification, increased physical activity actually wasn't associated with progressing to that threshold of 100 AU either. So this really throws a little bit of contradiction in that we have so many cross-sectional studies identifying increased CAC in endurance athletes, but looking at this longitudinal study, that doesn't really line up. So how do we put that all together? That's a complicated question. Main thing is that this whole understanding of CAC in athletes is really still evolving. So that was last time. Now we'll just get on with our cases, and Dr. Collins can start here. You're muted.
I will be presenting a case of atrial flutter in an endurance athlete. So a little bit of his HPI. Our patient is a 53-year-old male, no previous past medical history, who presented to clinic for exercise evaluation after a recent episode of atrial flutter. His story is about 2 months prior to presentation, he developed lightheadedness and palpitations while training, and presented to an outside emergency department found to be in atrial flutter. At that time, he was offered cardioversion. However, he did self-convert in the ED without intervention. Since then, he reported having one additional episode of lightheadedness and palpitations that ultimately self-resolved after an hour. He did not seek evaluation after that. Further about his history, no history of hypertension, hyperlipidemia, or alcohol use, no reported family history of coronary artery disease, sudden cardiac death, or cardiomyopathy. In terms of his exercise history, this has been someone who's been training rigorously since his 20s, a triathlon or participating in multiple triathlons since his 20s. He's an Ironman athlete and describes multiple marathons since his 30s. And at 53, really describes not taking any significant periods without training. Currently reporting about 22 hours per week, composed of biking, running, and swimming, and he incorporates about 2 to 3 high-intensity exercise training sessions per week. In terms of his objective data, normal tensive in clinic, heart rate of 52, resting heart rate, BMI 21.6. Other than that, his physical exam was unremarkable. In terms of pertinent labs, thyroid panel was normal, and cholesterol panel was also normal. Here's an image of his EKG in clinic with us. As you can see here, normal sinus rhythm, sinus bradycardia with a rate of about 54. And then this was his outside hospital EKG, showing atrial flutter with variable conduction here, which again, he spontaneously converted out of into normal sinus rhythm. In terms of further evaluation and workup, he did undergo cardiopulmonary exercise training. Of note here, his VO2 max, which is normal, which is quite excellent. His respiratory quotient here, which is 1.07, indicating maximal effort, above our cutoff of 1.05. Most of our endurance athletes can push themselves above 1.10, which I think he probably could have as well. Otherwise, normal breathing reserve, no evidence of pulmonary disease here. And then of note, he did have elevated a hypertensive response to exercise, a diastolic response. And then here's his EKG during CPET testing. Give you a moment to take a look at peak stress. And then he also wore a Zio patch for about 10 days. Here's a rhythm strip of his rate, minimum and maximum rate. Basically a normal study. He had a low ectopic beat burden, less than 1% PACs and PVCs, and no recurrence of atrial fibrillation or atrial flutter in this 10-day period. Here are some images. He had an echocardiogram. I'll show the peristernal long axis and then the four-chamber view. Here is the peristernal long axis. Is the video playing? And then his four-chamber view. Normal pumping function, normal EF here. Of note, he does have biatrial enlargement, which is normal remodeling that we can see associated with our endurance athletes, likely, predisposing him to develop these atrial arrhythmias. But otherwise, normal systolic and diastolic function here. And then I'll turn it over to Dr. So for our panel discussion. Questions?
Great. Thanks, Brianna. So it sounds like a typical endurance athlete, high volume, normal performance, but he's got at least probably at least 2 episodes of symptomatic atrial flutter, at least the first one, and we're assuming atrial flutter for the second one, otherwise normal testing. So I'll throw the first question to the panel. We always talk about AFib in athletes. But let's say, Dr. Dye, what do you think about flutter? Do you kind of treat it as the same as fib in this context, or is there any difference when you approach these patients?
I do treat these patients a little bit differently. Although there's a lot of different mechanisms for atrial fibrillation in athletes, a lot of it's thought to be sort of vaguely mediated or associated with additional fibrosis that happens in the atrium with stretch, with increased preload over time. Whereas flutter, especially if it's a typical flutter, is kind of more of a functional anatomic thing. Now, that can be kind of made manifest by any kind of additional right-sided stretch, especially if they have additional kind of preload on that side. But, I typically don't think of it being more vaguely mediated or sports mediated, but I do think they do very poorly with it. It's more difficult to control with medications. And I do think that typically treating them, getting them in sinus, that these patients do tend to do better. So in regards to mechanism, I think it's probably different, but in regards to overall treatment, with especially thinking of probably more catheter ablation being probably typically first line if they're symptomatic, treated in the same way.
All right, and attendees, you can type in questions now. We have a few example questions for the panel, but we'll take anything from anybody. Next question. Thank you, Dr. Dye. Kind of related to that, we'll ask Dr. Perez here. So, there's the whole thought that we can think about exercise reduction for fib. So if you can kind of expound on that, see in your experience, has that been effective, and does that work for flutter as well?
Yeah. So good question. So I agree with Dr. I'll start off by just addressing the first question, and I totally agree with Dr. Dye. We do see this. We do see some of these athletes come in with atrial flutter, but it's not nearly as common as AFib in the young athletes. And like Dr. Dye said, I think there is a difference in mechanism. And that leads me to just be a little bit more concerned about these athletes that I see with atrial flutter, because I just think that you have to have more of a degree of myopathy to get atrial flutter than you do with AFib. With AFib, we could postulate there's some stretch and so on, but that there does seem to be a much bigger role of sort of a pulmonary vein, triggers in athletes with high vagal tone and so on. But with atrial flutter, I mean, you almost never see it in the complete absence of underlying myopathy. So these, I follow all of my patients, or early onset AFib patients with imaging long term. But in the atrial flutter athlete, I would do the same thing. I would probably follow that athlete pretty closely, even after their ablation and so forth. Whether or not exercise reduction helps with AFib, we don't have a good answer to that. That hasn't been studied prospectively. Honestly, athletes rarely want to wait it out. They rarely want to reduce their exercise to see if things help. I mean, most of the athletes we all see in our clinics want to keep exercising, and as you all know, ablation in these young athletes for AFib, fortunately, does not result in a reduction of their exercise capacity. And with atrial flutter, we wouldn't expect it to either. But whether or not exercise reduction would be helpful in reducing atrial flutter, I think that we have even less data about. Now, there are some who suggest that if you start seeing athletes, endurance athletes who maybe are having a lot of ectopy or maybe short salvos of atrial tach, things like that maybe suggesting reduction could lead to a less of a chance of developing atrial fibrillation. But again, there's no data to support that. But in my athletes, I often, in my endurance athletes who come in with maybe not AFib, but maybe pre-AFib, if you want to call it that, I do mention it. I say, I understand that, sport's a big part of your life, but there is this link between what you're doing and AFib, and they very well may develop AFib. And I've had a handful of athletes over the years say, well, I love my sport, but, I want to take care of myself, my health even more. And so they do cut down, but that's the exception rather than rule.
All right. And then, I'm a basic non-interventional, non-procedure guy. So, I kind of think of flutter as something that's a one and done thing. It's pretty easy to do.
Mm-hmm.
This guy's got a huge atria. Does that factor in at all to the procedure?
I mean, yeah. I mean, technically speaking, for the procedure, no. But this again goes back to that idea that why does this not every young athlete gets a flutter? In fact, that's even rarer than a fib. So what is going on with what is the susceptibility that this athlete has? And this is an athlete who you probably want to make extra sure that you follow with echoes to make sure that maybe their atrial size is getting at least back to a normal athlete size, and is not developing any right or left ventricular dysfunction.
Yep. And I was just going to add too, depending on the age. So sometimes, if I see something I'm not expecting, sometimes you get in the CMR just to get a underlying basis, and you look for, and then in the ultra young, so like I treat a lot of active duty members. Always remember, if you see flutter in the very young, be suspicious that there's something else going on, particularly like an SVT, like an accessory pathway. And don't forget that men tend to start having evidence of Brugada around the age of like their 20s to 40s, and it's not always manifest on their EKG, but that also could be a harkening of something to look out for. So not in like the middle age to master athletes, but if you see an ultra young athlete, don't trump up flutter just to be associated with exercise. A lot of times there could be something else going on as well.
Yeah, I totally agree, Dr. Dye. I don't know what you practice, how you practice, but I pretty much do cardiac MR on all my young AFibs and AFlutters. If they're below the age of 45, then they're definitely going to. I mean, we do cardiac MR and genetic testing, so we're looking for those very very early signs or genetic susceptibility of cardiomyopathies.
All right. Thanks, everybody. Next question is Brianna. So Dr. Iyer, we'll get to you now. So this guy, what do you think of medication options for him? Let's say he doesn't want ablation. Do you think anything would be worthwhile for this guy?
Yeah, I mean, there's sort of the textbook answer, which we could certainly go through, and then there's the experience-driven answer when you've seen, enough of these patients. Most athletes are not at all excited about this. Typically, you'll encounter someone who isn't on any medications to begin with, and I always kind of take that into consideration. The difference between getting someone on 0 medications and starting their first medications is a pretty big lifestyle change, athlete or not. Then you throw in either the perceived or real impact of medications on performance, and people often are skeptical. In this particular patient, the ECG during atrial flutter, there isn't anything that super precludes it. I think anything with AV nodal kind of impact, obviously, it went a little slow on some of those cycle lengths, but there's nothing that strictly by the textbook would say that it isn't worth a try. We do have some guidelines on this. I don't think it's super helpful on this issue, especially after you've seen a few of these patients. Most patients are going to come to you with what they want to do, in my experience. Now, what I often kind of bring into the mix is just there is often a tension between a trial of medications if the timing isn't right for the patient to get an ablation, or they want to wait for the next generation of technology. And that always, athletes or not, we always trying to go through that balance for early stage AFib, where you're not going to lose the window to intervene on AFib if you wait 3 to 6 months. And so maybe it might be worth just as a palliative measure, a trial of medications. Pill in the pocket comes up a lot, right, in the treatment of AFib, but it sounds, at least from the history laid out nicely in the presentation, it doesn't look like this patient's going to be able to predict when he pops into atrial flutter and preemptively kind of give it, and it probably wouldn't make him too happy during the exercise. So, I mean, we can kind of go around the margins, but this is a patient you're probably going to be relatively aggressive with, and someone who's probably indicate their wishes pretty early. I probably would at least offer it pretty early in the guidelines. At least the recent ones seem to support that. I will say, to the other kind of comment here, it's striking how heterogeneous I think the mechanisms linking AFib and flutter in the athlete can be. In some patients it may be a little bit more fibrosis predominant, or pressure overload over long periods of time. Certainly that can be a driver. In other patients, it can be strikingly PV predominant, pulmonary vein trigger predominant. And in my practice, I think when you see atrial flutter, the real problem is in the left atrium. This patient has developed a substrate so that the electricity can circulate and re-enter into the right atrium. But the real driver, the trigger for the arrhythmia, is in the left atrium. The substrate that's perpetuating it is in the right atrium. So from that one and done perspective, anytime you ablate atrial flutter, that atrial fibrillation is lurking in the background because you've not really addressed the underlying trigger from the left atrium. And so most of these patients, they have something like a 1 in 3, if not more, chance of developing atrial fibrillation in the future with close and long-term monitoring, for example, with a loop recorder. So I think the left atrium can't be discounted, even if the problem is definitively right atrium.
Great, thanks, Dr. Iyer. I've got a panel of EP, so I'm not going to ask about this ablation question. We'll just let's go to wrap up here, Brianna. What do we end up doing with this guy?
Ultimately, our patient was very against any interventions. He wanted to avoid medications and procedures. He was offered an ablation. And his idea was to trial decreasing his volume, his exercise volume and intensity. So instead of the earlier reported of about 2 hours a week, he decided to cut that in half to about 10 hours and decrease his high intensity training to about 1 time per week. The plan for now is to continue to monitor him with annual surveillance.
Great. Yeah. So I could follow up. This is the patient from my clinic. A little bit unusual in that they didn't want anything done, but they seem to have, as you know, your athletes tend to try to find a way that works for them, and this patient kind of found a way that works for them. But he's obviously going to keep being followed because ablation is probably in his future. So yeah, thanks for the case, Brianna. Quickly go over some of the AFib, AFib data. This AFib and Endurance Exercise Association has been around for quite some time. It's important to note, though, that low levels of activity decrease incident AFib. So we're really talking about dedicated endurance athletes when we're talking about more AFib. Here's one of the early meta-analyses of several smaller studies, but the association with incident AFib and endurance activity definitely is there. This study notes a hazard ratio or an odds ratio of 5. Most analyses go somewhere between that 2 and 6 range, so right in that ballpark. Next slide. And here's a classic study. It's an observational study looking at Swedish skiers who do this long annual race there. And the main thing here is that you look at atrial arrhythmias, those skiers who are faster, so that's within the winning finishing time on the left, and those skiers who do more races have more atrial arrhythmias. And this study was mainly AFib. So it's really kind of nice that it illustrates that association with both intensity as well as volume and that incident AFib. Next slide. And then, so those previous studies actually were almost 90%, or not, if not 100% male. So the previous thought was that this is a male phenomenon, but obviously it doesn't quite make sense. This study is from last year. So here we go. It's in females too. Great study, long follow-up. Not many patients that develop FIB, but it's definitely there. Hazard ratio right in the 3s, similar to males. So this exercise association and FIB, probably males and females, something we all have to keep an eye out for. And I think that brings us to our next. Oh, there might be a question from audience.
Yeah, Jason, there's a question in the chat. I think it's pertinent and good to bring up about anticoagulation. So maybe a different answer with FIB and flutter. I don't know. That's up to the EP docs on the panel, maybe. But in this patient specifically, would anybody anticoagulate? And then I suppose in general, anticoagulation in athletes. In my practice, it's especially come up in cyclists who potentially have the risk of falling and head trauma, less so with like swimmers. But what do you guys think?
Yeah, I mean, I don't think we have data to support treating them differently than we would the general population, which is, you go by Chad's VASC and so on. But I mean, you bring up the important point that, a lot of these athletes are at risk for more bleeding, right? Contact sports, cyclism, and things like that. That I think the slightly harder question is if somebody has a Chad's VASC score of 2 or greater and is an athlete, and you ablate them, can you, after that 3-month period, can you safely take them off of anticoagulation? We don't know the answer to that, but I think that is something that many EPs would bring up as as an option for the athletes. But again, that's definitely not evidence-based.
So I guess in this patient,
one of these
particular,
where
you have a 50. Sorry, in this patient in particular, I guess you have a 53-year-old who with no medical history, so no, Chad's of 0, right?
Yeah,
Great, let's go to the next case.
Patient. Yeah.
Yeah, other questions to bring up about this athlete are do you do some kind of other monitoring, long-term monitoring for AFib? And I think certainly echo to look for myopathy. Whether or not you do an ILR or routine ECGs, or you get them to use a wearable technology to monitor for AFib. I mean, that, again, not studied, but I think would be a reasonable thing to think about.
think we get a lot of success with people wearing wearables too,
Yeah,
because
yeah,
or like they use it, monitor their heart rate and other things they do for exercise. And
yeah,
although it doesn't always diagnose well, the
yeah.
tracing have been oddly pretty good. Yeah.
Yeah, I think we're going to talk about wearables a little bit more in the second case. So, Dr. Keefe, are you sharing the slides? Are you in control?
I have control, I believe.
Perfect. All right, why don't you go ahead and start?
Okay. All right. So the second case is a 56-year-old, another triathlete. And he was on a training camp on Kona with a group of about 10 doing triathlon training. And during one of their morning bike rides up the hill there in Kona, he suddenly could just lost steam and got dropped by the group. Didn't really feel anything different. He did have a heart rate monitor and noticed a jump in his heart rate from about 140, where he thought he'd be, to 170. So he was unwell enough. They had a support van that picked him up and took him to the local emergency room. At that time, he didn't have a wearable device on. He just had like a heart rate strap. And so he went to the emergency room in Kona. By the time he got there, he's not sure when it happened. His heart rate dropped down. He'd taken his heart rate strap off at that point. So when he got there, his EKG showed sinus rhythm. He had a basic workup with labs and a troponin that were all negative. And so he was discharged and just kind of took it easy for the rest of the trip. And came to see me afterwards. It was interesting that the previous year on the same trip, another rider had developed AFib on the same hill. So I was starting to become known as the Kona AFib cardiologist. I was trying to secure an invite for next year. So this is a healthy guy, no past medical history, surgical history, takes no medicines, no family history of cardiac disease. I didn't put in his volume of exercise. It wasn't at the level of the prior patient. He was kind of an 8 to 15 hours per week type guy. He would do some shorter triathlons. He'd often do like a summer long bike ride or a long trail run. He did both. He had normal vitals, a normal cardiac exam, and his lab workup was all negative. Here's his EKG. There's a little RSR prime pattern there, but otherwise looks pretty normal. So he underwent testing. He had a structurally normal heart. His atria was not enlarged. We didn't do an MRI, although that's interesting. I'd like to talk more about Dr. Perez about what the age cutoff is to start doing MRIs on people with AFib. He had a very normal CPET, great exercise capacity, no arrhythmia. VO2 was 58. And our first clue that it was AFib, because at that point I wasn't sure whether it was a PSVT or atrial flutter or AFib, was atrial fibrillation that occurred just during sleeping hours during a 1 week Zio patch monitor, 2 weeks. So at that point, this is a guy who works in medical tech on the finance side. So he got an Apple Watch and started tracking carefully. And within a few months, he started getting more clear episodes of AFib. And these, for him, would usually occur after a longer bike ride. He would have often an IPA. And then that evening would start to feel AFib. And these episodes would initially self-terminate after about an hour. So this was impacting his life significantly. He stopped drinking altogether. That summer, he was planning to do a multi-day bike ride in Switzerland, which I'm probably going to mispronounce, the Haute Route, and just canceled that trip and started backing off. He stopped doing any long rides, was doing kind of shorter, less than an hour sessions, and continued to have episodes of PAF that he would notice on his Apple Watch, and they started to last slightly longer. So I could pause here, or I can.
Yeah, we can stop here and go to the panel for some recommendations. So I guess in terms of further workup, so far we've had the echo, we've had a CPET stress test, and then the Zio patch monitoring, and he's seen the further episodes on his Apple Watch at this point. So I don't know, Dr. Iyer, maybe we could start with you. Any further workup at this point? Either maybe a ischemic workup, or you mentioned the cardiac MRI. Would that be helpful in this case in an older gentleman? Not that old. He's 53, I think, right?
Yeah. Yeah. No, I mean, I think looked at the EKG there. I mean, we're always looking for some kind of substrate for AFib in these patients, family history, any evidence of pre-excitation, any kind of low-grade tachyarrhythmias on the Zio patch. But, I'm kind of with Brian, not really sure what our cutoff for cardiac MRI in a patient like this is. I think my sense is it's a little bit related to the availability of the technology and how much of a pain it is, and insurance, and there's like a little bit of a song and dance sometimes you have to do with a patient like this to get it done. After doing it, the diagnostic yield isn't terribly great. You may catch something occasionally, but I don't think it changes or alters your management in a patient like this. In the great majority of patients, I was involved in the care of this patient, so I'll hold off on any early recommendations for the patient. Turn it to the other panelists.
Yeah, I can talk a little bit about MRI. So in the non-athlete, young AFib population, our cutoff has been 45 years of age. And the yield of finding something unusual, even in echo-normal patients, it is actually pretty high. Something like 9 out of 11 patients that we ended up doing cardiac MRIs in our initial series. Now it's we've done many more. But it's a relatively high yield in the non-athlete population. In the athlete population, I think that yield is probably going to be a lot lower because we have other reasons for them developing AFib. I think the challenging question for me is always when I see these young, very young athletes get AFib is, I have a reason for AFib, but not every athlete develops AFib. So is there some other additional susceptibility? Could there be some other genetic susceptibility or structural susceptibility? So far, we haven't seen that signal, so I think MRI in this very young population, that's an athlete population, is probably going to be a little bit more challenging slightly lower yield. In the older than 45, I think it becomes even less. Unless you see something abnormal on the echo or something like that, I think it's probably a little bit less helpful. But yeah, young people who are not athletes, 45 is the cutoff that we've been using.
Dr. Perez, can you speak a little bit about the Apple Watch in terms of how it's monitoring? Do you know sort of the algorithm and how often it's checking? Because I think people, it's very popular. A lot of people wear it and think that they're getting monitored all the time for AFib when that's not necessarily the case.
Yeah. So a few things to know about the algorithm. So first of all, there are two ways that these smartwatches and Apple Watch and Fitbits and similar devices can detect atrial fibrillation. So one is with the light sensor. So there's an LED light and a light sensor, and that can produce a little signal when looking at shining the light on your wrist and seeing the reflection that correlates with the pulse. So essentially, the PPG is sort of a pulse wave data that's generated. And the way that algorithm works is that first of all, you have to turn it on, and it gets turned on in the background. So once you turn it on, every 2 hours, as long as you're not moving, every 2 hours there's a pulse check that lasts for about a minute. And if that pulse is irregular, then it starts checking more frequently, so every 15 minutes. And if 5 out of 6 checks are irregular, then the user gets notified that they have an irregular pulse that could be atrial fibrillation. So that's all kind of passive measurement. And then, you know, we typically would recommend doing an ECG patch to confirm, because you can't really make a diagnosis based on just pulse. But all you can say is that person has an irregular pulse. It could be AFib, could be a few other things. And then the other way, of course, is by ECG. And so many of these smartwatches now have the feature where you have to actively put your, turn on the application, put your finger on the crown, and get an ECG measurement. The algorithm is actually very, very specific. So the sensitivity is not great, but it errs on the side of trying to be more specific. And actually, both algorithms are designed that way. So if the ECG application, the automated read says that it's atrial fibrillation, it's very likely going to be AFib. But regardless, you as a clinician, when you get these patients, should review the ECG. And yes, the quality is pretty good. And then I think if you are able to kind of look at the primary data and agree that it is consistent with atrial fibrillation, then I think that's sufficient to make a diagnosis of atrial fibrillation.
Yeah, I think it's important to overread both of them, both the Apple Watch EKGs that are done, as well as the Zio patch isn't perfect either. There's a comment about kind of taking a look at the Zio and the algorithm on there, that those can be atrial tachycardia or other sort of irregular heart rhythms that get flagged as AFib. Yeah, it's good to remember that if it's checking every 2 hours, so it's really only going to pick up a sustained atrial fibrillation episode. Some of these shorter 10-minute episodes, it's pretty much impossible for the Apple Watch to pick those up if it's going through its algorithm.
Yeah, that's
Dr. Dye, I apologize. I cut you off earlier.
I was just going to add, because I have a lot of patients who wear these, that it has two options for the patients. One is the irregular heart rhythm notification, and the other is a AFib history. And so even in my patients with AFib, when they want to know if they are having AFib, I say, lie to the phone and don't tell them that you have AFib. Keep irregular heart rhythm notifications on, and then if you get an alert, do an EKG and send it to me. And they can literally send it to me, with a few clicks on their phone. So that's a little workaround that I've done for that.
Yeah, because as Dr. Keefe is alluding to, you cannot turn on both features. You have to choose one and not the other. And the problem with the AFib history is that, well, two problems. One is that it doesn't give you any real-time notifications. It only gives you that one time a week summary of how much AFib burden you've had over the last week. But the other problem is that the lowest value you can get there is less than 2%.
Less than 2%. So everyone says that. Yeah.
Exactly. Yeah. And so even if you have 2 hours of AFib, that's still less than 2%. So you won't know if you had any. So yeah, I know a lot of my patients do that, is they just, now if you're having a lot of AFib, then sure, or if you really, really already know, are very symptomatic with your AFib, and you just want to know how much, that makes more sense. But for one reason or another, Apple did not want that liability of of having people with AFib already trying to use the watch to manage their disease.
We'll go and move it along. So the next question would be, early, at this point, recommendations for treatment. So we kind of went through some of these already with the first case, but in this case with the paroxysmal atrial fibrillation patient in his 50s, probably CHADS of 0 as well. Any early treatment for him at this point? Dr. Dye, maybe you can comment on what you would do in this patient.
Yeah, I think for atrial fibrillation, because whatever you do, we have no cure for AFib. So really, for me, symptoms with the patient is what's most important. Like how they tolerate it, and then after that, what their burden is, especially in the setting of someone who's a CHADS CVAS of 0. Once they're a 2, then it's a totally different thing, because you're thinking about stroke risk. But how much burden it is, because that is going to change how much atrial stretch they're getting, how much atrial myopathy they're getting. But I really care a lot about their symptoms because, it's, to me, a low burden of asymptomatic atrial fibrillation. I think even medications could be too much, or especially in an athlete, kind of deleterious. It depends on what level of athlete they are. There's certain occupations or certain jobs in which you can't even use beta blockers or calcium channel blockers, especially because I'm active duty. Like, that down's a pilot. So if they're having less than 1% for a few minutes, even giving them a beta blocker or calcium channel blocker, it's not really worth the squeeze. And they're probably going to have more symptoms from the medication than potentially from the atrial fibrillation. Once they do become symptomatic, then, I have a conversation with them about medications versus where they want to do ablation. They just had the new athlete guidelines HRS update that, says now you could do class 1 for first line catheter ablation, but I still talk with them about it because it's a non-curative ablation, and although it's very low risk, I tell them, but antiarrhythmics are also not without risk. So I give them, talking about their symptoms, talking about, see what their underlying heart rate is and what they do and what their goals are, and we kind of make a team decision together.
So Dr. Keefe, what happened in this patient?
Okay, so he then had his first episode. It was probably actually a longer paroxysmal episode of less than a week, but it came on a Thursday or Friday and persisted through the weekend. And so at that point, he couldn't do much. His rate was controlled with no medications, but his exercise capacity was very low. So we started him on oral anticoagulation and did a T-guided cardioversion the following week. At that point, we started doing, I think on his next kind of longer episode, we initiated a pill and pocket option as we were starting to kind of ramp up towards thinking about other options. So that tended to work pretty well for him. If he had an episode, he would just kind of go home and take a dose of flecainide, and he wasn't having the overnight episodes at that point, but it was still happening once or twice a week. So at that point, I had referred him to electrophysiology already kind of tried number 1 there, but I guess these were the options that a few of the panelists already talked about. But if anyone wants to comment whether on a daily antiarrhythmic in an athlete who has a resting pulse of about 46.
Probably starts to get a little dicey, right? Just to say it out loud, but yeah.
Yeah, it's tricky. Yeah, I mean, the problem with class 1, of course, is that you should start them on a novel agent, because otherwise you get that risk of the one-to-one conduction. Although these athletes may not have that because they have such a high vagal tone. But yeah, there aren't that many options medically that won't necessarily impact their athletic performance. So very few of these athletes want, like the idea of being on long-term medications, much less an antiarrhythmic. This is non-randomized data, but there's a nice prospective study of ablation in about 140 athletes or so. It was done a few years ago, and success rates were pretty similar between athletes and non-athletes. But the one of the observations, again, this is non-randomized, but one of the observations was that athletes who tended to get an ablation done within the first 2 years, year or two, had better long-term success. Now that could be selection bias, certainly, but it's a little bit consistent with what we're starting to see in non-athlete populations, which is that earlier aggressive rhythm control long term.
Yeah. And if I may add to that, I do think a lot of times early is good because, we know that AFib begets more AFib. And a lot of times when AFib starts off, it's just really pulmonary veins. So if you get at that initial substrate without them starting to form a lot of non-pulmonary vein triggers, it's helpful. And then also in addition to like the class 1s with the AV nodal and the avoiding the 1-1 flutter, also remember that like flecainide and saphenone are sort of like use dependent. So a lot of times you really need to get them on a treadmill too, whenever I've ever do pill in a pocket or any kind of flecainide, because they can get some QRS widening and things like that. And then I'll see that sometimes in some of our younger athletes if they're even able to tolerate it. And obviously class 3s are sotalol is too bradycardic. Ticasant, although, has no decrease, you're admitted to the hospital for 3 days, you have that QT prolongation risk to it. So at this point, ablations are so safe, that it's sometimes kind of hard to make a decision to give them an antiarrhythmic.
Great. There's a question in the chat, kind of spinning off that. So let's just say there was a mild concern for CAD here. Do any of you guys kind of favor a cardiac CT, coronary CT and cardiac CT as kind of a way to get a twofer look at the coronaries and pre-plan for ablation?
Yeah, we used to use CTs for pulmonary vein mapping a lot more. I can't say it's terribly useful in my practice anymore. The quality of our electroanatomic mapping for true intraprocedural anatomic delineation is phenomenal at this point. So it's kind of obviated the need for that pre-procedural planning. Looking at the question, I guess it does a little bit depend on your index of suspicion of coronary disease. I think in this patient without much in the way of symptoms and breaking the treadmill and all that, I think probably would forego it in this case.
Yeah, I think in the athlete who you have higher pretest probability, I do agree that it is a good option. You're going to have a heart rate of 40. You're going to have probably really big coronary arteries. You're going to get a beautiful study. Going back to our panel discussion last time, it may not be totally normal. He may have coronary calcium, may have soft plaque, and I think it would be helpful for a lot of these athletes to have that knowledge as well, because we all, high levels of exercise, you feel chest pains, you feel things when you're on the limit, and it can be reassuring to know that there's no either soft or calcified plaque there.
Yeah, in this patient, I neglected to put it in the history, but he had a 0 coronary calcium score within the last few years, and with his VO2 of 58 and no angina and pretty benign lipid profile, I didn't pursue that.
That makes sense.
Yeah. So I can, if
Yeah.
we want to continue with the case, I think Vivek, you can kind of go through what
sure.
you thought about, and I can run the slides for you here.
Right, I think we covered a lot of this, the general treatment options, but this was derived from the recent, I think Cicely referred to this, the recent guidelines on athletes and atrial fibrillation arrhythmias. So basically what we discussed. We could go probably the next slide here. So what did we do for this patient? So this was, I guess it was a couple years ago at this point. We were, so pulse field ablation, obviously the new kid on the block in terms of energy source for catheter ablation. This patient, we were quite worried about the pattern of progression of the atrial fibrillation, the episodes getting longer, more frequent, requiring a cardioversion or nearly a persistent episode. And that'd be speaking some sort of remodeling, either in terms of structurally or electrically for this patient. And much like Marco was mentioning, we do want to intervene early, and I think you can get maybe a more definitive result, if not a cure, with that kind of strategy. So the patient was highly motivated to proceed with catheter ablation, as were we. We were at the time enrolling in one of the clinical trials of pulse field ablation, studying the Varipulse pulse field ablation catheter in the Admire protocol. This is a single arm study of pulse field ablation. Patient was eager to proceed. This is a electroanatomic map of the patient. On the left was kind of a superimposed map with the ablation lesions. On the right is kind of a before and after. And kind of to decode this, we're always looking for areas of scar or atrial dilation that sort of defines a substrate in an atrial fibrillation patient. So in this color-coded map, you can kind of see the four kind of Shrek ears coming out of the atrium. These are the pulmonary veins. And this is a color-coded map that delineates the voltage at every point, with purple, pink being kind of a healthy voltage, and red and green and yellow, those hues indicating some compromise in the voltage. That patch in the middle on the left, green and red, at first, we kind of thought that might be a little something, but, on careful remapping and touching the tissue a little bit better with an actual mapping catheter, ended up being uniform and purple. And this is kind of a single shot catheter, so it looks like a little circular lasso, and it sits in the veins. It's tremendously fast. I think we can go to the next slide. And it's able to isolate the four veins pretty efficiently. The unmet needs of ablation, I mean, this is taken from another presentation, but, we're comparing energy sources, thermal mediated energy sources, including cryo balloon ablation or radiofrequency ablation, where we actively heat or cool the tip of catheter and touch it to the tissue to destroy it. We always think about safety, and then there's an interplay between what is the safety in actual terms, and how early can we offer this technology to someone in terms of the number needed to treat to experience one of these outcomes. We want durable lesions, of course, that last forever, ideally, or for many, many years. Third bullet is not quite relevant. Speed is certainly an issue in terms of being able to ablate all the areas in the atrium efficiently with low anesthesia, and issues with recovery from extensive ablation. These are the kind of things that we sometimes encounter with radiofrequency. And in the athlete population, obviously, we want something that's relatively targeted, where the patient can recover and not feel totally beat up by it, and not lead to any of the feared consequences like stiff atrium or fibrotic atrium, where we're actually impairing the mechanics of the atrium. So the pulse field ablation struck us as a pretty interesting option for this patient. We can go to the next slide. And so this is kind of the another delineation of it. And the great thing about pulse field ablation, as opposed to radiofrequency ablation, is the radiofrequency is a little bit like napalm, right? It's heat, it's destroying everything in the vicinity. Pulse field ablation, we like to think of it as a more civilized energy source that is more specific for atrial myocardium. It spares the neighboring esophagus and blood vessels in the vicinity, although there's some questions about blood vessel spasm that are coming up, as well as nerves, which has an impact on what we think about mechanisms for an athlete with AFib and autonomics and so forth. But suffice it to say, the pulse field ablation is thought to be pretty specific to the atrial cells at play. And in terms of safety and recovery, that has very beneficial outcomes for an athlete, in terms of you don't want to experience that 1 in 1,000 or 1 in 10,000 injury to the esophagus. And that's something that never happens with pulse field ablation. We want the patient to bounce back pretty quickly and not have a lot of pericarditis or those kind of symptoms. Let's go to the next slide. And the workflow is very similar. You can typically get a skin-to-skin kind of either general anesthesia or moderate sedation for this patient, which is a nice difference from radiofrequency ablation. Skin-to-skin, something like 60 minutes. And otherwise, the workflow is very similar to what we're used to otherwise. There's some pictures of the X-ray that we could use. Most of these are visible in electroanatomic mapping, and very comfortable for those who have used other catheters in the past. So this is probably how we're going to do ablation in the coming 6 months to a year. I think at least 7-8 catheters are being designed and vetted, and all of them will have clinical trial data. So we're kind of looking for an option that is superior to radiofrequency and head-to-head evaluation, where most of the catheters that are FDA approved now show non-inferiority, although they do show some important advantages in terms of speed and avoiding some of these catastrophic complications. So more to come on this, but a lot of us in the field are quite interested in it. This patient, we can go to the next slide. This patient ended up, getting the pulse field ablation in the context of a clinical trial. Brian, you have the longer term outcome in this patient.
Yeah, he's actually a friend of mine. I texted him earlier this week, and he's had nothing since that. So he's doing great. Back to doing kind of whatever he wants.
right? And then this is kind of just a summary of a lot of what we talked about in terms of mechanisms and so forth. And I think a lot of times, even though the mechanisms of AFib in the athlete may come from X targeting the good old pulmonary veins, and the trigger for the atrial fibrillation will lead to a very effective outcome in a lot of these patients. You mentioned that it does differ in terms of how it tackles the autonomics. That's like the big thing that none of us can really study ever, really, but we're starting to unpack a little bit about the autonomics in atrial fibrillation, by stimulating where the ganglionic plexi reside in the vicinity of the pulmonary veins. And a lot of us feel that by doing pulmonary vein isolation, what we're really doing is modifying those ganglionic plexi, and thereby limiting the irritability of the cells or the perpetuation of atrial fibrillation. I think pulse field ablation, while it does activate nerves in the vicinity, it probably doesn't destroy the autonomics or modify them in the same way. But it does probably a pretty great job of the electrical triggers within the pulmonary veins. So this is an area that we'll all be keenly following in the months and years to come. And yeah, I think we're going to get a winner in it eventually, if we haven't gotten it already.
I was just
gonna
gonna
jump in with a question. There's one other question in the chat here. You're talking about autonomics, and I feel like I've personally seen in patients a lot of autonomic dysfunction during COVID and after COVID and long COVID. Has that been associated in your experience with an increase in AFib or A-flutter in athletes?
I am not so sure that it's tied to the autonomic issue, which is definitely a thing, but even absent to defined autonomic syndrome, I thought it was only me at the beginning of the pandemic where we would see like these little clusters, but very clearly for the first few months after a COVID infection or the vaccine, there seems to be a propensity towards atrial arrhythmias, any kinds of arrhythmias flurrying. It's despite all the cases of COVID, I haven't seen a really well done publication on this, aside from broad linkages. But we, in our group, we have seen many patients be very stably treated from an AFib or PVC or VT perspective, and then have COVID or the vaccine, and then have a flurry within 1 week. And it's just the timing is a little too skeptical to avoid. But I don't know if any of the other panelists have seen any good data describing this or the impact, but it's a thing.
All right. So I think unless there's any other comments, I encourage everyone to
Dr.
go
Manshadi
check
has
out
his hand raised in the audience. Maybe after that we can close out here.
Okay.
Amin? Yep, might not be able to talk. Sorry, Tim, we can close out.
I couldn't see any other hands, but anyway, so yeah, so I would encourage people to check out those recent guidelines that we looked at. I think it was interesting and applicable to this population. But yeah, I appreciate both of our presenters, Dr. Collins and Dr. Keefe, and our panel as well. We're about 1 hour, so I think that's where we wanted to wrap up. We're going to do another one of these in probably 3 or 4 months. We want to try to make this regular, so I hope to see you all on this again. Jason, I don't think we have a topic nailed down for the next one yet, but
working on that.
We'll be discussing that in our committee.
Great, thanks everybody. See you guys next time.